Bienvenue, welcome to this second workshop of Hospinnomics. Last year we had already a very interesting workshop. This one is devoted to big, smart data and their contribution to healthcare. I was interested in 2 years ago in reading a paper written by Murdoch and Densky called The Inevitable Application of Big Data to Healthcare, published in JAMA. And really at that time I didn't know that I would be asked by Martin Hirsch and by some colleagues to chair the scientific council of the Hospinnomics chair. I've learned a lot, obviously, in a few months. And I read a little bit more about big and smart data, realizing that, in fact, I was in some way practicing big data, smart data, and even very smart data in the case of high blood pressure. Well, we can say that this strategy leads to the generation of new knowledge. New knowledge is new power as well. And especially because it's possible now to analyze unstructured data contained within electronic health records. And they contribute to observational evidence for important clinical questions. Also, big data, smart data, help to disseminate knowledge. They can guide clinical decisions for patients with multiple chronic illness, like diabetes, degenerative diseases, high blood pressure, and so forth. They also are important to translate personalized medicine initiatives into clinical practice. And obviously, they are also important because they integrate nowadays genomics with electronic health records, and we will discuss that later on. They can also implicate the patients themselves in healthcare, and they can improve the medical record with personal data found on other sites. Also, last year, there was an important report of the Stratégie nationale de recherche, National Research Strategy, which was provided to the Ministry of Research and concerning mostly the big data and coming from genomics, proteomics, and also health records, and pointing out the possibility to link those data with huge data banks coming from the SNIRAM and PMSI, saying that in fact in this report that France was probably one of the largest dataset bank for administrative data in the world, with 1.2 billions of feuilles de soins, ordonnances per year, 500 million of medical acts, and 11 millions of hospital stays. As I said, without knowing it, I was practicing very smart data with my colleagues in Hôpital Broussais and in Hôpital Pompidou, because we had, since 1975, electronic health records of hypertensive patients. This was set up with the help of Patrice de Goulet with a program called Artemis. And because we see approximately 1,200 to 1,300 patients a year, we have a data bank of 40,000 hypertensive patients. These were done in a structured way and in a prospective way, because those patients, for most of them, were patients who were followed. Of course, what we would like to know, and we are not still in the capacity of doing, is to link these records with administrative data, or at least with death certificates, re-hospitalization, and so forth. Nowadays, it becomes possible. And now I hope with the data bank we have in Hôpital Pompidou, 17,000 patients, 17,000 patients, to be able to follow up this patient, to do data mining, linkage with PMSE and CNAM, thanks to several collaborators coming from the medical information department, from the research center in the Cordelier, and of course in our hypertension units. At the same time, as a clinical scientist, I realize the difficulties which are encountered during this type of study. With my perspective, again, of a clinician scientist, it's relatively easy to do with a monocentric database, even though there are, of course, information retrieval which can be difficult to do in case of prologicial update. But when you deal with multi-centric databases, you are dealing with ontology differences. You are dealing with difficulties of non-redundant, semi-anonymous identification. You are dealing also with the problem of reliability of data from complementary database, especially in France with the death certificates, which are sometimes not correct or not realistically exploitable, I would say. And of course, this is an important point also, we have to consider the ethic problem, because it's difficult, if not impossible, to get informed consent in retrospective database analysis. There are specific problems due to data linkage. Direct consent, for example, is one of the solutions. Saying that, I think it's really now time to give the word to the round table. Thank you for your attention. And Pierre-Yves Geoffard, with Lise Rochek's acting in this chair, will lead the discussion. Pierre-Yves.
Okay, thank you. So I won't be long because we all want to hear the speakers. Just a few words. This year workshop is devoted to data, to the question of data and methods. For PSC and as a whole, the issue of data is of course very important. It's at the heart of many of our research projects, including not only the exploitation of existing data, but also production of new data and in particular, the use of administrative data for research perspectives. So the question of open data, of course, is also an important one. There's the thing that we all know, that there's lots of gold mines with unexploited data, which could be very interesting for research and also for evidence-based decisions. And one of the objectives of the chair has been and will be to promote the access to such data and to build research projects around this data. Now, thinking about the subject of this workshop, talking about big data or smart data in health. So why do we need very large data sets? Well, it depends. It depends on the question we're asking. For many research questions, survey data is fine. But then, if we're interested in rare events, rare diseases, on survey data, you simply don't have the power to analyze such issues. If you're interested in specific populations, then on survey data, you won't have this kind of information. So having very large data sets is key to looking at such issues. Another issue is also inequality, especially when one variable is very, very polarized or very concentrated. If you have survey data, for instance, if you're interested in the distribution of income, not talking about health, income, well, survey data is fine because you have, well, a certain distribution. But if you're interested in wealth, survey data usually is not good enough because wealth is very, very concentrated. So you need to have either a specific survey or administrative data, which brings lots of information about some areas in the whole distribution on which you want to focus. Now, thinking about, that's for the big part. Now, for the health part, thinking about what is specific to health data in the whole environment of administrative data and of open data. I think there's two issues which are central to the issue of health data. One is linkage, and we will come back to that question later on. So being able to link, especially administrative data coming from different sources, from the health insurance, from the tax income, the income tax data. If we are able, from the schooling system, if we are able to match and to link this data, then we got an enormous power to analyze many phenomena. So that's the first point. The second point, which may be not specific to health, but very important in health, is not linkage, is leakage. It's that we have to be, as soon as we're talking about health data, and we're talking about individual data, we must be very careful about leakage, and we must be very, very careful about the protection of individual data. That's important, because if there is any mistake or any error, the consequences may be very dramatic for the future of this linkage and of building huge data sets which are useful again for evidence-based decision and research. So without further delay, I will introduce briefly the speakers. So I suggest we by order of appearance, I suggest we start with Randall Ellis, who's from Boston University, and who will tell us what he thinks is smart data. Then we will move to Emmanuel Bacry, who is a mathematician working at the École Polytechnique, and he will talk about the statistical and mathematical approach to big data, and with a focus on health data, and with some details about one ongoing project with the National Health Insurance system. Then Geneviève Chen from the University of Bordeaux and Avison will talk about sequencing, and we'll also say a few words about the National Health Data System project going on. And Franck Lewey, who is an ex-founder of Criteo, but now has projects in health data hébergement. How do you say that? Storage. Thank you. And who will react to the others, and also say a few words about his own project.
Well, I'm very glad that the topic of this was changed from big data to smart data, because that is a very smart move. So good for you.
Not a big move.
I was thinking in preparing my thoughts, and I wasn't allowed to use PowerPoint, so this gives me an excuse to just talk and be animated, that there are kind of 4 dimensions of smart data. One of them is that in this day and age, big is good, because it gives you more power to look at means or run models on subsets of your data. And it used to be, when you took statistics, you probably learned that 30 was asymptotically normal, and by 1,000, you know, everything is well behaved, so you can use your regression models and not worry about non-normality. That is simply false, of course, with healthcare spending and things, where you need to get up to 1 million or really big numbers to even get just the distribution of means looking reasonable. But it's even more important if you're looking at rare subsets of your sample, in which case you might need tens of millions or lots and lots of data, more than you're going to survey, in order to find those 1,000 or 10,000 people who have some rare disease. And one example of that, I've been worrying about the cost of disease. There's this rare disease called Gaucher's disease. It's named after a person, Gaucher, and it appears in less than 10 people per million. So even when you have 10 million people, you still only have around 40 of these people, and you can pool multiple years trying to pin down their costs. And the reason that's interesting is the drugs alone in the United States cost over $350,000. And so this is a very rare disease that costs a lot of money, and there's a lot of imprecision about the cost at the individual level, and that's an example. The second feature of smart data is that you have to have it clean. And I'm afraid I spent endless months of my life, as some of you have probably, cleaning up data to get rid of duplicate records and throw away the negative spending and all of the dirt. It's just a huge challenge working with data. And that's why having somebody else do that for you and warehouse it makes it wonderfully more valuable and productive. And there's any number of dimensions in which data can be cleaned, and that includes making sure you can identify which people they are, or which states or provinces or zip codes in the US. Those are kind of very useful things. The third dimension that I would feature on smart data is that you have made it linkable, if at all possible, that you could link it to other types of data. He mentioned, Pierre-Yves mentioned that there is the possibility of linking mortality data. The truth is, in the US, we cannot link mortality data easily to most of our insurance claims because that's maintained by a separate agency, and unless you're working with Medicare data, it's very hard to do. But there are other examples of linking, for instance, the geographic information of where the patient lives, or what are the other suppliers in the neighborhood, or what is the temperature or the water quality. All of these issues are very exciting topics to link for health economics. And so to the degree that you can link other information to your database, it just multiplies its value, takes a lot of time, and again gives you a real asset. When you've done that, you want to take advantage of your data. And then the fourth dimension of smart data, I would say, is that you have organized it in a way that makes it easier to analyze. And there's an awful lot of big data sets out there. I happen to work mostly with commercial claims data, and over 7 years we have about 50 million people per year, so we have over 300 million person years of data, each of which has many, many claims. So the data set that I'm using takes up currently 1.7 terabytes for one copy of all of these claims and eligibility information. And of course, if you realize whenever you're analyzing data, you need room for storing a couple of copies or versions of that data. Forget about backing up, that's assumed, but you need to have area to sort your data or rearrange it. And so being incredibly organized about the variables you drop and the observations you drop, how you shape your data, that is the real value that makes you able to do things quickly compared to starting all over again with raw, unorganized data. Now, at BU, they have a big data meeting of people who work with big data, which I went to the first meeting or two, but I learned that I don't actually have big data. So it was interesting because the people who were there were the physicists and the astronomers. And if you imagine scanning the skies looking for stars or dual planets or things, they have truly, truly monstrous, they measure it in, I think its next level is petabytes or whatever instead of terabytes. But there are bigger data sets, although they tend to ask very simple questions, unlike the diverse ones that I like to look at. But the beauty of these large data sets is if you get them organized and you get to decide, how to weight your observations so you're not having to process as many, throw out all the zeros, for instance, focus in on the subsample that you might like. These are all really easy ways of shrinking down. And when I teach my PhD students, I tell them about make the file skinny, drop all the variables you can, make the files short, drop as many observations. If they're all zeros, just put a weight on there. You could have 1 million zeros. They take up one record instead of taking 1 million records. It speeds up your programming time. And the other secret to my work is to be sure you found an efficient computer to work on. And most of the time, your work in this area with big data is not going to be determined by how fast your CPU is, but it's going to be driven by how quickly your I/O is on your storage device, because you're going to be reading and writing out data a lot. So these are some of the tricks I have in using smart data. Let me mention one project that I'm doing that also highlights the interest that you can approach health economics from many different directions. I happen to come from a background of econometrics and industrial organization. So I like to think about markets and how do incentives change behavior. And the issue in the United States is that we have chosen in the US, for historic reasons really, to allow lots and lots of different kinds of health insurance plans. So in France, you pretty much have one main plan and then you can buy supplementary plans, but you have a standardized insurance coverage, not the US. The US has, hundreds of different kinds of insurance plans, and the argument from the insurance is, oh, see, they're saving money because we're motivating people to use less care. So it's called demand side cost sharing. Make the consumer pay and they won't use as much care. So that sounds attractive, and there's evidence of that, although most of the cost savings happen because you shift the burden onto the patient, so the insurer and the employer are not having to pay the full premium. But the interesting question is, we also have these health plans that constrain how many choices you have. They give you narrow panels of doctors. So that's a supply side method that you can also control costs, not by making the patient pay, but by forcing them to choose from a skinnier panel of doctors and hospitals. We call those narrow networks or exclusive provider organizations. And so the interesting question is, which one of these two strategies saves more money, narrow panels or cost sharing? So that was the question we wanted to address. And we had this wonderful, sample of data. But in order to really pick it up, we wanted to control for all the endogeneity that people choose plans. You see, it's not a random group of people in each plan, so you have to worry about the type of people in a plan differing if they're in a generous plan from people in a less generous plan. That's the selection issue that's pervasive in the US and many healthcare markets. So what we did is we wanted to put in a person-level fixed effect, an individual dummy for each person in our data, and then look at changes in spending among people who move from one plan type to a different plan type. So that is one of the better ways of controlling for the sickness of the patient, that now you've controlled for that. So in our sample of 5 million people, we needed 5 million dummies. Now again, that turns out to be a relatively complicated model. You can do it just by absorbing some means, but econometrically, that's an interesting challenge. But we also wanted to control for the 50,000 doctors we had in our data. So now it's called two-dimensional two dimensions of high fixed effects. So it's not too hard to do with one dimension, but 2 dimensions non-symmetric, non-balanced panel is quite messy to do. So that turned into a very interesting econometric challenge, which ended up taking over the paper. And we finally wrote some estimation algorithms that we were proud of, and we wrote a second paper. So my interest in the market led to conceptualizing the data, choosing this large sample, and then very challenging econometrics to control for this two-dimensional fixed effects. What did we find? Well, it depends on how you look at it. Yes, the high cost sharing does save money, mostly by cost shifting, but the narrow panels and the HMOs seem to be about as effective. So for me, that's a really nice finding, because it satisfies that I do believe that an approach that focuses on supply side incentives and choosing what doctors and hospitals can do may be as effective or better than demand side, pounding on the patient to try and get them to do the right thing. So what does this have to do with big data? Lots of organizing the data, thinking of clever models, ways of organizing it for your work. We did not use this concept of cubes, which are extremely popular in the US and in the big data space. I'm hoping my other speakers will cover that. I'm not an expert on cubes, but lots and lots of people find different ways of cross-cutting your data to simplify it. But there are other techniques you can use that simplify your estimation algorithms and try to minimize this burden of nonlinear estimators in gargantuan data, which are kind of difficult to do. So I don't know if I've been going 20 minutes. I think I'm about on time. But I do think that smart data is our future, and I've been focusing only on one aspect, the claims that I've been using. The two other big areas in the US are medical record information, which tends to be a multiple of the size of the information that's present in insurance claims. Insurance claims in the US, and I suspect here, is the information that doctors and hospitals send to the insurance company in order to get paid. And so it only has to satisfy financial information as compared to medical record information where the doctor may have lots of notes about lab test results, what did the patient say, how are they feeling, medical history. There's a lot more detail in medical record information typically. And that is harder to analyze partly because of irregular timing. It's very hard to make a rectangular file out of medical record information. So that's, I think, the big challenge on medical record information. And the second and even more elaborate kind of information that's available is the continuous time measurements that often arise from things like heart monitors or MRI scans or CAT scans. Those are they would go through multiple terabytes just in one day in some of these imaging techniques, and trying to analyze that information is beyond me. And I think in most processes it would be a different challenge to try and use that information. But I mention it because there are other kinds of information, such as some of you might have little hand-worn devices that are continuously reporting your blood pressure and your heartbeat back to some computer on the cloud, and somebody is analyzing that data, and there's going to be some interesting questions that they can answer with it. And those are all examples of things that can be done in this big data, smart data world that we're all approaching. I think I'll end there.
Okay, so I'm a researcher in applied mathematics, and I'm going to try to give you what are, from an academic point of view, what are the new scientific challenges from applied mathematics and computer science. I'll try to do both, give you many examples from everyday life, and then I'll focus on health at the end. And as other people here, I don't like the term big data. And especially because when you say big data, people keeps asking you, okay, there is a critical size above which it's big and below which it's not big. And there is no such a critical size, of course. And, okay. The main thing about smart data and big data, the core issue is how to extract. I have a problem here. Yeah, clean data.
Clean the data.
Yeah. Is to extract information from the data. So at the core of that, it's data science, I would say. Okay? Extraction of information from the data. And there are various factors that can make this extraction hard. I will just list a few of them. And we very often we forget about that. Maybe the problem is complex, and that's the most simple factor. Let me give you an example. I'm sure you have a lot of you who have laptops. You have pictures of your children on the laptops, and when it's the birthday of one of your child, you want to find all the pictures of this child, even if it's in a group or so on. There are plenty of softwares to do that, and they don't work. Okay, we all agree that they don't work. This is a very complex problem. It's not big. It fits on your hard disk. Okay, but it shares some techniques of what we call big data or smart data in terms of machine learning, statistical learning, and stuff like that. Okay, so that's the first thing that is, I think, important to say. Second thing, the speed you want to make the extraction. If you want the information very fast, then of course it's going to be hard. The variety of the data. Of course, we are far now from the time where you had the person and just the age, the weight, and the size. Now you have X-rays, you have the genomic data, you have the sound of the voice, you have the environment that the person lives in, and so on. So that makes, of course, all the algorithms and all the methods to extract the data much more difficult than before. And then at the end, you have the volume. Of course, If you have a lot of data and you have to spread them on several hard disks, several computers, then everything is more complex to perform. The extraction is more complex. The acquisition, the cleaning, the storage, the analysis, and the visualization, everything, every step is much more complex. So data science is a pretty old science, okay? But there is a new scientific context that changed things, okay? And basically, it's due to the recent developments in both computer science and statistics. And I just listed a few points, I think. So computer science, the fact that we have now, and it's in the late, let's say, last 10 years, we have high computing, much higher computing powers, either cloud computing, so many computers working together, or one big computer with a lot of processors in it, okay, GPUs or MPPs. And in terms of applied mathematics, so call it artificial intelligence, data mining, machine learning, statistical learning, I don't care. There have been a lot of developments, and I would like to talk about something. It's the difference between two different approaches. There is one approach in machine learning which starts with examples. So this is, for instance, what I was telling you about the photos of your children. You're going to say, this photo, here is my children, this photo, and so on and so on. So you give examples. This is called supervised learning. Okay? Now you have a whole class, much more difficult to elaborate algorithms, which is unsupervised learning, where you don't give any examples. So for instance, you have a set of texts, and you want the algorithm to extract automatically some themes. So a theme could be revolution, 18th century. That would be a theme. Okay? And you want the extraction to be automatic, and you don't give a list of themes. The computer has to find, the algorithm has to find the themes by itself. So you don't give any example. Okay? So that's unsupervised learning. Let me show you a few examples in your everyday life where you have this kind of machine learning going on. Of course, first thing, internet search engines. Okay? The funny thing, if you do a search on motor de recherche on Google, you don't find Google. That's really something. Okay, so what's behind that? Huge quantity of data, more than 1,000 billion web pages, I think, that keep changing, so that makes things very difficult. The pages change, and there are new pages every second. You have to answer pretty quickly, not very quickly, but at least less than 1 second is good. And then when you have a lot of solutions, you have to rank them. You can sort them according to the audience, meaning a page on which a lot of people clicks. You can sort them by the popularity, meaning a lot of links to these pages, to this page. Okay? And you can also sort by relevance. This is where you have unsupervised learning. So what do they do is to take all the web pages and extract some themes, as I said. And then when you request something, they compare the themes they found to your request, and that's how they also use the rank. So there is a lot of research on this thing. Advertising, of course. We all know these pop-ups things that normally bothers everybody. But so the algorithm has about, the whole chain is about, I think, 20 milliseconds to decide which advertising to pop up to your screen. Okay, and here is the whole chain more or less. Okay, so this is very complex. You start there on the left, and you go all the way here to find the right ad, and then you go back. That's 20 milliseconds. And in between, you have, I don't know, 20 people, 20 different companies that are involved. So this is very, very quick. Many actors are involved, and a lot of them are using machine learning, supervised or unsupervised. But we have a specialist here, so I'm not going to talk about that too much. Next thing, recommendation. You liked that movie, so you might like this movie. Or you bought this book, you might want to buy this book. Okay, it's used everywhere on the internet. How does it work? It's called collaborative filtering, because basically you are using, so this is supervised learning, because you are using what other clients have been doing in order to induce what you could be doing. Okay, so it's like having a huge array where here you have the clients, here you have the items, and whenever a client buy or saw an item, you just make a cross. So you have this huge matrix which is full of zeros almost, and there are a few crosses. And the goal is to try to guess more crosses, to add more crosses. You want to add more crosses. So we call that matrix completion. So you have like a matrix and you have to complete it. So I want to give you an example because it's funny, you know, in math, you take an algorithm and you use it in somewhere else that you don't even think of using it there. And it works very well. So an image is a matrix, okay? So let's forget 65% of the image, 65% of the pixels, okay? And I want the algorithm to find these pixels back. It is an iterative algorithm. So we'll see the first step, which is pretty bad. Second step, and then we go on. There is no trick here, right? We arrive to that. Okay, starting from the 35% of the pixel, we arrive to that. How did it work? Well, the different rows worked collaboratively. Okay, you understood, because there are some structures, very nice structure in this image, so that's how it works. But this is the same algorithm that can be used by Amazon and Netflix or stuff like that. Social networks, of course, this is unsupervised learning, because you want to find clusters in order to understand the structure, the geometry of the different people involved in the social network. Okay, so that's one example. Now, what about the new scientific challenges here? First thing I think which is very important is that there should be a strong interdisciplinarity. So that's today on the market, when you try to hire a data scientist, you have the choice between the applied math who knows a little bit of computer science and the computer scientist who knows a little bit of math. And clearly we need somebody who knows both, and it's very hard to find in the market today. Hopefully it will change because there are a lot of masters opening now with both teaching, but it's going to take time to change. Second thing, I think that's also a key point in order to make progress on data science, is to have strong link between academic world and public institution and or private companies. When you are in the academic world, if you want to work on data science, you need data, and the data, they're on the right part here, and you need concrete applications to make progress. And that's not that easy because data, you know, people don't like to give it away because it's supposed to be so, you know, so much money behind that, so that they are always afraid to give you the data. Challenges in computer science. You have to design new languages, new frameworks in order to be able to program these cloud computers or these HPC computers. Okay, so there are a lot of research is being done on that. You have a lot of freeware coming out every day. New database system. I'll talk a little bit more about NoSQL. You know, so not only relational database. No is not for NoSQL. It's for not only. Challenges in machine learning statistics. So I told you about supervised learning, which is relatively mastered. There are 2 points that people are working on. Scalability, meaning that you want it to be able, these algorithms, you want them to work on a huge amount of data, which is not that easy. You want to reduce the number of passes over the data, the I/O you were talking about. Yeah. You want to reduce that. And the other thing is the large dimension. Let me explain that on a very specific example. This is classic statistics. You have the users here, the people, okay, a lot of people, and then you have few, what I call dimension, few factors, so like the age, the size, and the weight. So 3 columns and a lot of people. N is the number of people, D the number of factors. So the classical thing is N much larger than D. And today, D is extremely large, okay? D is extremely large. There are several possibilities. D is very large, but N is still much higher than D. So it's kind of classic statistics, but on big data. D could be of the same order of N, or D could be much greater than N. Okay, if you take that, if you consider that one person, you have to take the genomic data of the person. That's a lot, and then you take a lot of images and so on. You arrive very quickly to D much greater than N. Okay, and you can imagine even a situation where D increases with N. So when there is a new user, then you have to invent a new column for this user. Okay, so how do we solve that from a mathematical point of view? You have to do some parsimonious hypothesis, meaning what? Meaning that the information you're looking at, you are going to make the hypothesis that it relies only on a few factors. You don't know which one, but you are making the hypothesis that just a few factors are sufficient. And now the algorithm is going to try which ones. Okay? So that's a crucial hypothesis today on supervised learning on big data, okay, in order to have efficient algorithms. And I would like to talk about that, but maybe we'll talk about it during the discussion. There is an issue here also, which is that most of the supervised learning algorithms are kind of black boxes. So you might maybe predict very well the probability for somebody to have a heart attack, okay? But you don't know exactly what are the important factors, because it's very hard to read. It's like a weird combination of a lot of factors and nobody can read it. And that's also, of course, very bad. You want to understand what's happening. And that's very rare. In most algorithms, you don't really understand how the decision is made. And of course, that makes a lot of regulation problems. And we can talk about that later if you want. So I talked about supervised learning and unsupervised learning. So here, in terms of research, there are so many things to do. We are at the beginning of unsupervised learning in some ways. Okay, so there are still many things to be done. So at Polytechnique, we have this thing which is called Data Science Initiative that I'm heading. So we are doing teaching and so on. So if you want, you can join us to the Data Science Starter Program. If you want to learn about big data, it's twice a year. So that's my advertising here, my pop-up slide of advertising. 10 weeks, 2 days a week. Okay, but the goal of the initiative is also to develop strong links with public institutions and private companies. Here is a list, and actually we developed a whole research poll on public health. Okay, and I would like to talk about one particular partner, which is the CNAM, Caisse Nationale d'Assurance Maladie, who is the public health institution which takes care of all the reimbursement for the health cares, okay? So at the heart of the CNAM, there is this database that you mentioned more or less, which is called SNIRAM. So SNIRAM actually is a set of different databases. The main one is DCIR, which is an accountant database. So whenever you buy medication to a drugstore or you go see a doctor and so on, whenever you ask for reimbursement, there is one line in the database. Okay, so that's really the core database. Then it is linked to PMSI every month, I think, and to some other database like long-term illness database. And the total makes one of the largest health database in the world. So that's 65 million people. It's a little less than 1,000 terabytes of data. Okay, so that's really big data here. That's very clear. So, of course, with a potential very, very high impact on both health, but I guess I don't have to convince you. But just to give you two examples that the CNAM did in 2013. They proved that there is a link between the third generation contraceptive pill and pulmonary embolism risk. And in 2014, they made a cartography of 54 important pathologies. So they developed a certain list of criteria for all of these pathologies. So, for example, for HIV, there are 50 criteria. Okay. But of course, a huge impact. So I'm not gonna. This sounds stupid here, right? A huge impact on economics. I'm not so sure. You'll tell me if the number is right. The French public health budget is 170 billion, I think, euros a year. Okay, so you can imagine the impact. And you can, with using this cartography, you can, for instance, just quantify the cost of the different pathologies or stuff like that. That you could imagine a lot of different impacts. So at Polytechnique, and I must say thanks to Pierre-Yves, we have a partnership over 3 years with the CNAM. So it started the beginning of 2015. And for this partnership, basically the CNAM opens the whole SNIRAM to us. Okay, so it opened, but we have to go there. Of course, they don't give the data. Okay, and you don't give 1,000 tiras like that. With some research themes, and I listed a few of them here. Identification of useful factors for analyzing economic health pathways, detecting weak signal in pharmacoepidemiology, detection of fraud, and we have a few more. We are a group of about 12 people, and I would say like there are 3 computer scientists working full-time on this database. It's a big thing, and the first challenge, the main challenge, is to design not new algorithms, because I mean new techniques, because basically the techniques exist, but they don't correspond scalable algorithms, meaning an algorithm that can run the techniques on huge amount of data. So that's where we have to design some new things here. And of course, before doing that, we have to pre-process as you mentioned also, we have to pre-process the database, okay? Because you have to understand that the database of the SNIRAM is an Oracle database, relational database with 1,000 tables, okay? And at the center of it, you have the prestation table, so the care table. It's not centered on the user, okay? So whenever you buy medication, on the center table, you have one new line, pointing towards you, towards the doctor who prescribed the medication, and so on. So you have a lot of... So if what you are interested in is try to understand what is the health pathway of somebody, you have to do a lot of research, and that's going to cost too much time. So you have to reorganize the whole database. Okay, so the SNIRAM must be flattened into a non-relational, not only relational database, so a NoSQL database. So it depends on what you want to do with it. If you are interested in a project which is centered on the user, then you have to do a user-oriented flattened database. So it means that you have a huge array with all the users here and everything, all the health events on each line. Okay. Now, if it's centered on the doctor, you have to do a different processing. So NoSQL database, it's very nice because you have very few constraints. You can have a lot of missing data. You can mix images and whatever you want, and even in the same column, you don't have to have exactly the same type. So it's very flexible, and you still have efficient requests. But of course, there are some bad sides of it. The two mainly bad sides is the fact that you increase significantly the size of the database. So let's say at least 3 times. Okay, so we're talking about 3,000 tiras now. And the conversion from SQL to NoSQL is a huge process. You need clusters in cloud computing and stuff like that, and it's going to take weeks doing this kind of thing. But you have to do it. There is no way you can run supervised or unsupervised learning on an Oracle database. This is completely crazy, and to have to do the link all the time. You have to reprocess it, so we have to go through that. So this is, I'm not going to talk about that, just to tell you that like this NoSQL world is like a world which is continuously changing, because a lot of people are working, so you have like plenty of choices, so you have to be careful using the right choice that, you know, and this is a very important choice, a very important decision, not that easy to do, because things are constantly changing. And I would like to finish my talk here by mentioning, oh no, sorry, I wanted to talk about one thing. Okay, when you convert to NoSQL database, there is still one question. Do you keep the same structure for the health events or not? Either you stay with the same basic structure, so you don't really reorganize the database, so this is the low-level structure, or you are saying, okay, maybe if there is this doctor who prescribed this medication for 3 months to this person, I'm not going to say that there are single events of buying this medication every month for a year or whatever. Okay, I'm going to say that this is one event. Okay, so I'm going to structure, because I know little about the database, so I'm going to structure it. So it's nice to structure it because it's going to be simpler for the algorithm to run. Otherwise, the algorithm will have to find that all these buying medications is about the same problem. But on the other way, if you do that too much, then you might put some bias in your database, because you think some stuff and you put it in the structure, and maybe then you keep the algorithm to find something different from what you expect. So there is like a middle structure to find, which is not that easy, and of course you have to work with experts to do that, because you have to know a lot about the database and the meaning of the database. So last thing I want to talk about is another project we have, but it's pretty connected in terms of research to the CNAM project. It's a project with Hospital Tenon. It's connected because it's an excerpt of the SNIRAM database over 10 years on use on the people who has prostate cancer. Okay, so it's about 2.4 million persons since 2004. And here are the kind of things we're going to start working on. So the themes. The first one is we're going to try to find the consequences of prostate cancer, like secondary effects of prostate cancer. So this is unsupervised learning. This is exactly as what I was talking about the text. Okay, we have these people who have the prostate cancer, and we want to extract consequences, but we're not going to list consequences. The algorithm has to find out what are the consequences. It might be a combination. I'm going to say something really stupid, but it could be like fever, and then you have an X-ray like that, and then and so on. Okay, but I don't have any idea a priori, and the algorithm has to find the themes by itself. So that's unsupervised learning. And the second project is supervised learning. It's a specificity of diabetic patients that are taking diabetic medication at the same time as prostate cancer, to understand if it helps the prostate cancer or not. Okay, so this is, for those who know, this is classical survival analysis. So it's supervised learning, but here the challenge is the fact that we want to be scalable. We want to use it on a huge amount of data that you do not do normally for survival analysis. Voilà. So thank you very much. And if you want to have more information.